Now Bill Sause is here from Intermountain Health, and he will present the perspective of an integrated system. Thank you, Bill.
Kind of an integrated system. That's what I'll talk to you about. So my talk's going to be fairly eclectic, and I think it's going to touch on a lot of the topics that people have talked on already this morning, and hopefully I won't rehash what other people have done, but hopefully some of the examples are complementary. And I have no disclosures. I am employed by Intermountain Healthcare, and I want to specifically thank Brent James, who's been my mentor for many years, that really is the inspirational leader for a lot of these processes. So how do we do this? The green one on the left? In the middle. Okay. So Intermountain Healthcare. Intermountain Healthcare is a large healthcare organization that really evolved from the LDS hospital church system. So it really covers 500 miles. It covers the entire state of Utah. And Intermountain Healthcare cares for between 50 and 60% of the lives in the state. So that really sort of represents a clinical monopoly. That's a curse and a blessing. It allows you to do some things other healthcare systems can't do, but it also carries a big obligation with it. And a lot of the things I'm going to show you have to do with the general population. There's no discrimination between Medicare, Medicaid, uninsured, indemnity insured. They're all put in one basket and they're all looked at, and the health care delivered to all those individuals is virtually the same. So it really is the state health care system. Now, one thing it is not, it's not an HMO. So the physicians are not employed by and large in the system. There is a cohort of people that are employed, and in some regions there's more employment in other, in some specialties there's more employment in others, but it's really a disparate system. And probably 2/3, 3/4 of the physicians that work in the system are fee-for-service medical providers just like anybody else. So it's not a seamless, self-contained system. And the way the system was initially set up were that each region or each geographical delivery system was sort of autonomous. You know, it wasn't one centralized bureaucracy. But ultimately, the goal is to improve the quality of care by developing quality improvement strategies that proactively and consistently support best clinical practice. Now, I don't want to get into the debate about what's best clinical practice. Others have done that. But this is an iterative system. What we do is measure outcomes, identify outcomes, collect the data, feed the information back to the clinician, and then restart the wheel again. In my mind, guidelines are useless unless you measure the outcomes. I mean, guidelines are ubiquitous. Every society, every guild has their own set of guidelines that generally favor their guild. Unless you measure how care is delivered, the guidelines, in my mind, are sort of useless. And the way that Intermountain set this up is to develop clinical programs. So oncology is one clinical program, and then it sort of transects the services, of which pathology would be one, radiology would be one. So radiology quality care, pathology quality care, respiratory quality care would be sort of, when it had to do with oncology, be under the oncology clinical program. So that's how it was structured. And Intermountain Healthcare has a long history of superb data systems. I think in the last decade or so, Intermountain's maybe lost ground to the rest of the world, but initially their data systems were exceptionally robust compared to the rest of the world. And data systems, quality data systems, are imperative to do this work. And I'll show you some concrete examples of what we've done in the past, but we never did anything without using at least two data sources. So if we measure clinical outcome in some way or adherence to a guideline in some way, we always tried to have two mechanisms to look at that, so we weren't trusting one set of data system. So it's the right data in the right format in the hands of the clinician who operates the process. And that's sort of the goal of this whole thing. And, you know, these are the quality improvement projects that we did in oncology in the last decade or so, and I'm not going to read them, but they're immense, and they're very, very labor intensive, and they require a great deal of infrastructure and energy to do this. And I'm going to focus a little bit on diagnostic imaging and pathology, since that's the purpose of the conversation. But this is, in my mind, sort of the poster child for what we've tried to do. And this is the adaptation of a sentinel node biopsy in women with breast cancer. And interestingly, the main hospital in Salt Lake City, LDS hospital at that time, was the second leading accruer on the NSABP sentinel node trial. Second leadest accruer in the country. So it wasn't for lack of knowledge. It wasn't for lack of interest by the clinicians at the major hospital. But when you look at the system, we were less than 60% of people with breast cancer were getting sentinel node biopsies in breast cancer. So if you think about a system priority, you have to think of the whole thing and not just one facility. One facility can be unenlightening. So if we take, this is an imaging example of quality improvement project. If we're going to look at mammography, for instance, what we do is map out the process. Patients will get a normal, incomplete, probable benign, BI-RADS 3 or 4, 4 or 5, and then follow down the algorithm of how the care was received. And then we look for variation in how the care was delivered, and then feed it back to the clinicians and try and change their behavior. And this is the callback rate from a variety of physicians in the system. So you actually measured this, and the callback rate is from 6% to 16%. That's quite a variation in callback rate. We show this data back to clinicians, and we lost half our mammographers, which is fine. These were people that didn't do a lot of procedures. They were happy, quite frankly, not to be inferior radiologists, and they choose to do other work. But it was the feedback system and the quality improvement that allowed this to occur. Most recently, we've looked at MRIs as a utilization in breast cancer. And you can see they vary from 7% to almost 50% use of MRIs for primary breast cancer in our system. And these are just the major facilities. We haven't addressed this problem yet, but obviously this is variation. The clinical outcome's the same. Cure rate's the same. Obviously, the utilization of resources is going to be substantially different. And a current practice is to look at false negative mammograms. That's what we're currently doing right now as a quality improvement process. We might lose another half of our diagnostic radiologists, though I don't think so. So to switch gears a little bit to pathology, this is sort of a apple pie and motherhood pathology process, which was to look at 12 node sample at the time of colectomy. You know, it's a standard of care. There was variation in the system. Now we're at about 100%, but this was probably one of our first pathology processes. But again, feed the information back to the clinicians. And this is a team approach. This is not just pathology. This also involves the general surgeons. So, one of the things we obviously looked at was estrogen, progesterone positive breast cancer. Did they receive adjuvant hormonal therapy? This just outlines the number of patients who had ER-positive tumors. But this data reflects that this is a living process. If you had your breast biopsy toward the end of the week, you were much more likely to be ER negative. Strange, because the specimen sat on the table for the weekend, the protein denatured. Next week it was negative. That determines whether you get adjuvant hormonal therapy or adjuvant chemotherapy. And the only reason I show this was it was kind of a eureka moment for us. But this is a living process. It's a dynamic living process. you have to look at the data. You have to understand what you're doing, and you have to then feed it back and apply it and change how you're practicing medicine. And remember, this is a system approach. 500 miles of hospitals, 23 hospitals. Currently, we've looked at our OncoDX. This came up earlier earlier today. People talked about using OncoDX. We, again, looked at our patients that received OncoDX testing, determined whether they had Herceptin or not Herceptin, or whether they had adjuvant chemotherapy and no adjuvant chemotherapy. And one of our smart pathologists took the major components of the OncoDX testing, worked with other universities, Hopkins and University of Pittsburgh, and came up with this McGee score. McGee score takes in proliferative index, ER/PR, and HER2 status, gives us almost the same results as the OncoDX for $200 instead of $2,000. So it's a iterative process that we go through when you look at these kinds of quality initiatives. And this is not new science. We're taking sort of quote unquote standard of care and just implementing it. So the challenge is, historically, the clinical program hasn't had any authority. I'm in charge of the oncology clinical program, but I don't employ any physicians. So, and I don't own anybody's paycheck. So most of what you have to do is the bully pulpit and cultural. And we've heard that word a lot today. The regional hospitals had independent priorities and budgets. We were competing with the ER and CV, et cetera. Medical staffs weren't aligned in any way, 500 miles apart, different reimbursement models, and we had to compete, as I say, with other clinical services. But the opportunity is, I think we've been doing this for a long time, and it's clear where we need to make changes to move ahead. We need to restructure the management team so the clinical program does have some authority. We need to eliminate the regional competitive model and centralize the budgets. We need to centralize low-volume procedures like pancreatectomies over 500 miles, and that's a challenge when every physician is sort of WRVU-based. We need to restructure the reimbursement with the value-based model. Even Intermountain is beginning to realize our data systems are somewhat arcane, and we're going to use, Rich may be happy, we're an early adopter of ASCO Cancer Link. We've purchased a CPM, a care process model vendor via Oncology. Again, strengthen physician alliance, leverage healthcare. One big advantage Intermountain has is we do have our own health insurance, which represents about 20 to 25% of the volume of the facility. So that is a nice leverage point. And what we've already done, some of the things we have already done to centralize the process is we have molecular tumor board, which is system-wide across the system for all the new next-gen sequencing and all the new molecular testing. That's televised across the system. And we can, from biopsy to results in treatment, should be about 2 to 3 weeks in our system right now. Bill asked me to talk a little bit about telehealth. Oncology hasn't been one of the leaders in telehealth, but I'll just give you a good example here. We have been using telehealth as a way to standardize care and quality across the system. This is for the intensive care units. And we focused on the 7 community hospitals that had ICUs, but did not have a full-time intensivist in a large geographic area. Those were the people that we thought would be most vulnerable in a system like this. And we adopted telehealth for those facilities. And interestingly, you can see the number of people that died in the ICU went down, survived the discharge went up, died during hospitalization went down. So it's been very successful. We're going to expand this probably to non-IHC facilities across the Intermountain West. So very similar to the last talk that you heard about pathology, this is one thing we're going to do with intensive medicine. And we have developed a telehealth service for oncology, primarily outpatient medical oncology in some of the rural settings. This will undoubtedly expand over the next decade. But right now we have about 5 sites, very rural sites. The other real opportunity, I think, for telehealth is in medium-sized communities where you don't have subspecialization. You've heard a lot about subspecialization today. And they're specialists, but they're not subspecialists. And I think the opportunity for telehealth is to provide subspecialty care to a generalist who may be in a medium-sized community. Not so much a community where there's no help, but in the medium-sized community where you already have a specialist, you can augment their care. And I think that's the big advantage, in my view, of telehealth and oncology. So I think the key requirements for quality improvement are cultural. I don't know how many times we've heard that today. It's not unique. Obviously, we need infrastructure. We need better systems. Somebody mentioned today that our EHRs are designed to capture charges. They are designed to capture charges. They're not designed for this kind of work. And we need to improve those. We need leadership. We need engagement of the clinicians. And I really think a lot of the engagement has to do with the metrics. We're so focused on metrics that are imposed on us from outside by payers, by other organizations, that we're losing the clinicians because we're not providing them real metrics to help them take care of their patients. And then the other issue, and this goes hand in glove with bandwidth, and I've heard that 100 times today too, physician burnout. We just can't layer on. We have to figure out how to take some things away to make this work, because clinicians they're burnt out. They're going to get burnt out, and they don't want to spend their time sitting in front of a blue screen. They want to spend their time talking and seeing the patient. That's why they went into medicine. So we need to figure all that out. So thank you.